This video includes a presentation read by the speaker.
My name is Dr. Rhonda Holliday, professor in the Department of Community Health and Preventive Medicine here at Morehouse School of Medicine. Today, we are excited to welcome Dr. Karen Albright, who will be presenting on the topic, Population Health and Advocacy, Promoting Health Equity. Before I introduce Dr. Albright, I want to review a few housekeeping items. We ask that you place your questions in the chat or hold your questions to the end when you can raise your hand and unmute yourself. We would also like you to complete our evaluation. The link for the evaluation will be placed in the chat throughout the presentation. And just a reminder that today's presentation will also be recorded. Now, it's my pleasure to introduce to you our speaker today. Dr. Albright is a senior investigator and director of community engaged research at OCHN, an associate professor and director of qualitative research in the Division of General Internal Medicine at the University of Colorado School of Medicine. She holds a PhD in sociology from New York University and completed postdoctoral fellowships at the University of California, Berkeley, through the Robert Wood Johnson Foundation Scholar in Health Policy Program and at the UCLA Center for Culture and Health. Her research focuses on health disparities and the social determinants of mental and physical health among socially economically disadvantaged populations. She is particularly interested in understanding individual and system-level factors influencing health behaviors, identifying behaviors to care, and testing potential solutions for improving care. She seeks to understand how organizations and institutions structure, culture, and processes affect dynamics within and across healthcare. Not only for socioeconomically disadvantaged patients and consumers, but also for providers in the system. Dr. Albright, welcome, and it is my pleasure to turn this over to you.
Thank you so much, Dr. Holliday. I really appreciate it, and I appreciate all of you all who are here today. If you'll give me just a half a second here, I'll share my screen, and we will get going. Okay, I hope everyone can see that. Again, I'm so grateful and excited to be here and really looking forward to the discussion. As you know, I hope we are here to talk today about population health and advocacy, which is one way of many to think about avenues and pathways to promote health equity, which is what I have devoted my career toward, and I'm sure many of you have done the same things, which is why we're here together today. Let's see if I can for the slide. There we go. So Dr. Holliday has already given me a very nice introduction, and just to hit some of the highlights again that are maybe relevant for my approach to tackling these kind of issues. I am indeed a sociology PhD, and some of you may be as well or have a background in sociology, but I like to say that sociology is a discipline that has perhaps been branded a little funny or has demanded a little bit of more explanation over the past couple of decades since I received my PhD. But I find it enormously helpful as a disciplinary background and training for skill sets, particularly around health equity. And the way that I choose to apply my sociological perspective here is really in two ways. I've always been interested in inequality and the consequences and implications of it. And in the past decade or so, in particular, I would say that the systems level approach that sociology often takes to issues has been enormously helpful in my work. So I've been very interested in social determinants of health, but also the systems level factors that influence those social determinants of health. And with that training, I have been a health services researcher for more than 2 decades now. And as Dr. Holliday said, my interest in health and in health equity was really honed during my postdoctoral fellowship period, where I received great training, a multidisciplinary training that helped me understand the world through multiple perspectives. I am now a faculty member at the University of Colorado School of Medicine, and I head up the qualitative research core there. And I am also a senior investigator and director of community engaged research at OCHIN, which I'm very excited to tell you about because OCHIN's pretty great. I hope all of you might look it up, ochin.org. OCHIN is a nonprofit that connects more than 1,700 safety net sites of care, including community health centers, federally qualified health centers, school-based health centers, rural centers, and behavioral health centers together across 36 states through a single instance of EPIC, electronic health record. And so we have an enormous community laboratory of sorts with working with folks that don't often get attention in our healthcare or health services research world. So it's a wonderful place to learn more about, and I'm thrilled to be a part of it. So our talk today is really, I think a good place to start is to dig down into what we mean by population health. Forgive me if I am explaining the basics. Again, I know there are a lot of experts here in the audience, but I think it's good to kind of level set. So when people talk about population health, we're really talking about, the health status and the health outcomes within a group of people, right? Not looking at the health of one person at a time, which is that's a common pitfall that people often think about. We are all individuals. We live in our own heads. We think about how the world affects us as people first, and that's perhaps true for health more than any other aspect of our lives because we experience health individually. But when we're talking about population health, we're really looking at a very broad overview, right? Like looking at what's happening with a group of people. And so when we work within population health, we're trying to improve the health of, a large population. And so that means health outcomes, that means patterns of health determinants, which is what I'm particularly interested in. And it also means policies and interventions, which over the course of my life, I would say, my professional life, I have gone from just simply observing or documenting differences in patterns to really feeling compelled as I move into middle age here to make my time count and to try to put some of my effort toward policies and interventions that can actually move the needle a little bit. And you all are also probably familiar with this concept of health equity. But again, it's good to level set here at the beginning of the talk. So what we mean by health equity is that everyone has a fair and just opportunity to be as healthy as possible. And that means doing a whole variety of things, but including removing obstacles to health as best we can, like what often falls under this, broad umbrella of social determinants of health, but poverty, discrimination, and the consequences of those things that can trickle down in about a million ways, but including powerlessness and lack of access to good jobs that have fair pay, quality education, housing, safe environments, and of course, healthcare. And all of these things are really interrelated. And when we try to measure health equity, what we really try to do is drill down on ways that we can show demonstrable effect in terms of reducing and ideally, ultimately eliminating disparities in health, particularly those that adversely affect excluded or marginalized groups. That's a tall order, as we all know, but that's what lots and lots and lots of people, including you and me, are trying to do with our lives to try to chip away at this huge boulder that is unfortunately a pretty big mainstay of our modern life. And some of you may have already seen a graphic similar to this one, but I really like this because what it does is show the difference between equality and equity. And most people, of course, in their daily lives and in sort of common language will use the word equality. But over the past couple of decades, I would say people have started to realize that giving everyone the same, or thinking that everyone is starting from the same place and or needs the same tools is not actually the best approach. So you can see here on this top row, in this case, everyone has the same size bicycle. But you can see that that size bicycle only really works for the person who is second to the right here. That fits her pretty well. But the first one is too big for the little guy, a little kid, and and it's too small for the third person, and the person who is in a wheelchair can't use the bike at all. Versus when we think about equity, you can see that everyone has the size or kind of bike that is appropriate for them. Thus, everyone is able to, actually use it and actually get where they're going. This is obviously a simplified version of this, but that's what graphics are. And I really like it because it underscores how thoughtful we really need to be when we are devising plans or implementing plans to try to get everyone to improved health outcomes. So I already have mentioned we define population health, and I have already mentioned the social determinants of health, including in the role that they've played in my own career interests. So I want to talk a little bit about how these inform each other, again, with this idea of kind of level setting before we move on to the advocacy piece. But when we really talk about population health, again, we're trying to talk about reducing health inequities or health disparities among different population groups. And the reason that those inequities or disparities exist is because of these social determinants of health. And those determinants are really, again, I mentioned it's sort of a broad umbrella, but they're really all the factors, right? It's a lot of factors, but social, environmental, cultural, and physical factors that different populations are born into, that they grow up in, and that they function with throughout their lifetimes that all told, all together and individually, have a measurable impact on the health of human populations. And so when we think about population health, it really represents this change that has historically changed from the focus that's been historically in place from this individual level characteristic. And most of mainstream medicine is oriented still according to this individual characteristic, which again makes sense given the history of modern medicine and the ways that individual bodies need to be treated when disease occurs. And it also represents a change, or complements rather, a change to these classic efforts that you all are probably all familiar with in public health, where have long been, very important efforts and effective efforts to address a number of factors that we know impact the health of different populations. And the World Health Organization's Commission on Social Determinants of Health, which is now almost 15 years old, but was very pivotal and very important in the development of this field, has said that these factors are responsible for the bulk of diseases and injuries, and they were the major causes of health inequities in all countries. So the most recent estimates that I know of estimate that these social determinants account for about 70% of avoidable mortality. That's, as we know, pretty significant. And you can see here another depiction of these social determinants of health. I think in different measures or different graphics, these numbers the percentages may be a little different here or there, but you get the basic idea that there are, there's issues of quality of care, access to care, the physical environment, healthy behaviors that we engage in at the individual level, which are also determined by or count as social determinants of health because they're shaped by those in the environment that we live in. And then there's social and economic factors like education, employment, income, family and social support, and community safety. So all of these things here, these buckets or these parts of the pie, are considered social determinants of health. And the last graphic I have on social determinants of health is this, again, another depiction to show the breadth of them. And you can see here, it goes from the biggest umbrella part, these general socioeconomic, cultural, and environmental conditions that we all live in, sort of the soup that we're in or the ocean in which we're swimming. And then there are the second outer level here. This is often what people name when they talk about social determinants of health. But then those things also then go ahead and contribute to the social and community networks, then individual lifestyle factors, because we're all actors on a continuum where we can make better or worse choices, but those choices or that continuum itself is constrained by these outer opportunities or limitations. And then there's the demographic factors that we had generally speaking, have no say in, right? Things we were born into, accidents of birth, our age, our sex, and so on. So social disparities, we know, leads to, as I've said before, health inequities. And again, you all know this, right? So these are the result of avoidable differences between populations, and they stem from this pattern of health determinants and outcomes, and this is important, resources associated with these inequities. So when we have patterns of social exclusion, or blocked opportunities or unequal returns on effort based on these factors that are these social determinants, these factors that exist above us, when they're common to a population, then what we have, among other things, are differences in health status and healthcare. Again, there's lots of things that also result from that, but since we're talking about healthcare, this is something that we can directly see, differences in access to care, differences in quality of care, and thus differences in health status. And low socioeconomic status or socioeconomic disadvantage, which I've been saying for years and years and years, and still I sometimes verbally trip over, we know in particular is associated with an increased risk for many diseases. And those certainly include cardiovascular disease, arthritis, diabetes, chronic respiratory diseases, and cervical cancer, as well as for frequent mental distress. It really affects pretty much everything. So if you're on the lower end of the socioeconomic continuum in our society, you're almost certainly you're going to have worse health outcomes than someone who is on the higher end. But again, we're looking at this not really at the individual level, we're looking at broader population patterns. So a way to think about it is that specific diseases might change. Fewer people, let's say, hopefully almost no one is getting tuberculosis right now, but other diseases move into the forefront. So specific diseases changes, but the burden of being low socioeconomic status does not change. The lower socioeconomic status populations always get the brunt of poor health. And again, there's lots of different ways of thinking about how all this happens. We've talked already here about the broader environment of social that is created by and continues to create social determinants of health. And here we can look at, to try to ground it a little bit more in our biologic processes. You can see here how this burden really takes shape and has impact. And this is a sort of a classic figure depicting the stress response and development of what is called allostatic load. So you can see, there of course are individual differences. We are all individuals with our own unique or relatively unique constellation of characteristics at every level in society. Things like genes and development experience. And so, but when we experience stress or perceive stress, because we're all living in our own heads, right? When we perceive stress, then we will have, there's sort of a cycle that occurs. We will perceive stress, we will have a behavioral response of some kind to that stress. You know, I'm sure you've heard many people refer to fight or flight. Certainly that's true. People will also make a variety of different choices in their personal behavior that will make things worse or better in terms of alleviating or dealing with the stress. And then there are physiologic responses that come from that. And all of this is kind of informed by these environmental stresses we have and major life events, and certainly with any trauma or abuse that we have experienced. So really, this is just to bring home the point and to link it to our biologic selves, that the stresses people feel, and of course, the point I'm making here is that while everybody experiences stress, everyone, this too is the extra burden of those who are less socioeconomically advantaged for the most part because of these environmental stressors that they are much more likely to encounter. But so when we experience stresses, you know, or essentially people's stresses are influenced by experiences as well as genetics and behavior. So this is, again, an extra burden for people who have these additional environmental stresses, um, especially all the time.
The next slide features a complex infographic with several sections. The title reads The Continuum of Community Health and Well-Being, from upstream on the left to downstream on the right. Beneath this is a series of health considerations, illustrated by a road with different points labeled along its run. Beneath the road, text reads Roadmap of Opportunities for Health Systems to Build Health Equity.
So here we have a pretty complex figure, or at least it's pretty busy. And I'm going to use this now as a jumping off point for the rest of my talk, because what this depicts is not only a roadmap of opportunities for health systems to build health equity, but it also is drawn from the project that I'm going to be sort of referring back to periodically for the rest of the talk. And that is a project that I worked on a few years ago that was funded by the Robert Wood Johnson Foundation. And it was connected with, it was sort of a joint effort between Robert Wood Johnson and what was then Catholic Health Initiatives, that has now, CHI has now been subsumed under the All Common Spirit, excuse me, the Common Spirit umbrella. But it represents a significant number of health systems within its network. And this project in particular was meant to build, to understand kind of all the different factors that were going on in Catholic Health Initiatives, you know, efforts to combat or to build health equity. And it was a really impressive multi-pronged approach. And so I think it's a good basis for this talk. So you can see here that there are a number of opportunities to build health equity for health systems. And only some of them, I think, are usually in our consciousness. So there's issues that range from, you know, social equity work over here on the left side, institutional equity work, community culture of health categories of work, wellness, which we're starting to get now into what we think of as the health domain, and then certainly categories like advanced care and end of life. So this is meant to represent, again, a whole spectrum of opportunities where we can intervene as advocates or as providers or as researchers to contribute to a more holistic understanding of what we're really looking at here. And hopefully in this age of feeling relatively fatalistic about a number of challenges that our country and our world are facing right now, hopefully looking at this and thinking about the different opportunities for intervention and areas and domains that where you can have an impact. Hopefully this feels maybe a little proactive. That's how I feel about this and this kind of work. Feels like even though sometimes these things can feel like a drop in the bucket, it is a very clear way, or these represent a very clear way of contributing and doing good. And I am personally buoyed by seeing the range of possibilities here. So when we think about when we think about the ability here to build these pathways and make this work meaningful, I think it's important to think about context, right? This context pathways framework. And so you can see here again, population health. This is these are the focus of work that you can engage in here. Really focuses on physical and mental health, right? So you could do in a study or in some sort of advocacy work, you can define a population and then proactively, in whatever ways, with whatever tools are available to you, proactively address the mental and or physical health for the population with which your organization is directly responsible, right? If you want to be more expansive and look at total health, you can also encapsulate in that the social and or spiritual well-being, and or the community health and well-being of those populations, because certainly we are all complicated, multidimensional people with and populations with a variety of dimensions that can be where effective work can intervene. And when we think about the this portfolio 4 here, the looking at place-based and community organizations and defined populations according to place, and we're seeking to look at whole community transformations with a focus on long-term structural changes that are really required for a thriving, equitable community. What we really need to bring into play here are anchor institutions.
The following slide features an image of a town map with a hospital in the center, circled with a dotted line.
And what do I mean by anchor institutions? These are institutions. Here you can see there's this rather inartfully drawn dotted line here is highlighting a hospital, right? So I'm trying to center the health system here in this equation. But you can see here, you can think about anchor institutions as being really key to improving access, improving and addressing diversity and inclusion issues, and really being catalysts for transformation. I think we often forget about ways to tap into and the importance of these anchor institutions when we think about social change, because for so many of us, sometimes these anchor institutions have historically been problematic. We don't view them as nimble, and we're in so doing, in sort of disparaging them or that aspect of them, we often forget that they're really essential to advocating for and moving the needle on true change. And so anchor institutions are important in and of themselves, of course, but they're also really effective partners with other agencies, right? So we can help, they can help, in this case, this hospital or another kind of health clinic can help us understand the basic human needs of patients, can help communicating and coordinating with other agencies to address those needs, and can contribute ultimately to the development of effective plans to reduce disparities.
The next slide features images representing local government, universities, hospitals and health systems, and community and place-based foundations.
So in terms of definitions, we're looking at nonprofit or public institutions, that are what some people say have sticky capital because they are rooted in place. This is an important characteristic in particular with today's day and age where so many things are virtual or digital and don't seem to be anchored to a particular place or community. But anchor institutions are indeed that. And they're also economic engines, right? They're, for the most part, they're large purchasers and employers and investors. So they are ripe for being turned into, if at all possible, these catalysts for change. And so I offer that to you to not dismiss the role in engaging these institutions in your own work to advance health equity. So the rest of the talk then is going to be looked at, I'm going to be focusing on how we as members of these anchor institutions or people who dialogue or interact with these anchor institutions, can commit to or help to commit to transformational change. And this is where the advocacy work really comes in. So I'm going to touch on four main buckets of I don't know, potential change here, right? These aims to promote health equity and improve population health. I'm going to be saying a little bit about how we can transform our role as providers, how we can strengthen our role as community organizations, how we can strengthen our leadership accountabilities, and how we might consider changing our policies to support and advance health equity. And I know that's quite the list of things to do. So I will continue to get to it here. So transforming our role as providers. You know, I mentioned I'm going to be drawing for these examples on my previous on this previous project with Catholic Health Initiatives and Robert Wood Johnson. And for me, this really really encapsulated what many people are doing elsewhere too to transform their role as providers into a role that is particularly sensitive to and accounting for these social determinants of health and understanding the role that those play in individual lives. So in this particular project, we integrated community health workers into care teams and integrated universal screening and referral for unmet basic human needs into the clinic workflow, which, by the way, it's funny to just mention that as one bullet point, because of course, again, and many of you are doing very similar work, of course, but it's funny to reduce it to one bullet point because anybody who's doing work in this area knows how complicated that is, how deeply important smooth integration into workflow is for any added component of any kind of work. And so, of course, a lot of thought and planning and failure and ultimately success went into that bullet point there. And we also developed robust resource databases and tried to engage coalitions of trusted community resources. And these activities were all in service to trying to help providers address basic human needs and essentially to achieve better health for their patients. And actually, in the process, not just having patient health be improved, but to contribute to a more local understanding of actual needs and effective referral and support pathways. You know, every clinic or every site of care, every health system is a little bit different. Um, there's a lot of similarities across systems too, of course, but the orientations that providers and that the system itself has toward individual patients can vary across a lot of different factors. And doing the best we can as researchers, and you can, or others can, as providers and people working within those systems, to really let providers and the care teams understand again, the multidimensionality and the complexities of each individual person and the environment that they're living in is crucial. It's crucial for patients' health, but it's also crucial, I think, for the providers and care teams who work with these patients for better understanding, more holistic understanding of the people that they're working with. And certainly that's easier said than done, but lots of different activities can happen to make that work.
The next slide features a table of potential topics and associated screening questions and follow-ups, including food security, housing, utility needs, financial resource strain, transportation, exposure to violence or personal safety, and literacy.
So here's an example of some of the screening questions. I won't linger here too long because I know, again, a lot of you are doing similar work or have incorporated this already into your work. But you can see here how these screening questions essentially tagged, these broad categories of social determinants of health. And in so doing, this really helped the providers understand their patients and the limitations of what some parts of their lives were. And it also fostered a sense of trust and appreciation across that dynamic, which was invaluable. So here with lessons learned, again, you've done some of this work already, but there were a number of lessons learned that we took away, all of which you can read here. But the point really is that you need patience, and you need humanity, and you need thoughtfulness, and you need to, before you implement any kinds of new changes to workflow, you need to really make sure that people are on the same page with why this is important and what the benefits are, and also that the benefits go far beyond any measurable impact in individual patient health, but it changes the whole dynamic of the provider patient or clinician patient or care team patient relationship. So here, these are principles to strive for as providers, right? We're collaborative, ethical, equity-driven, and evidence-informed. We communicate clearly and honestly to build trust and foster transparency. We embrace and celebrate diverse perspectives. We're committed to continuous learning and quality improvement, advocate for access and coverage for health services that address basic human needs, and that the requirements of in the system that the providers work in are designed to ensure the appropriate process and technological frameworks, and make sure those are in place to support effective use of data to understand better needs of our patients and inform improvements in care delivery. There is you can see this quote here I have on this slide. I always like this. Always design a thing by considering it in its next larger context. A chair in a room in a house in an environment in the city plan. That's how we need to think about the way that our patients experience health and healthcare, right? We need to design our health systems and our interactions as providers with the patient's orientation and perspective and experience in mind. That may sound basic, but it is not done nearly as often as it should be. Individual providers, of course, are overwhelmingly, in it because they care very much about patients and improving health. But still, we're all actors within these larger systems, and sometimes the health system can drive it out of you. So as much as possible to have providers understand these basic bullet points and orient the healthcare system and the practice and individual interactions with patients to support this is very beneficial. Now, another place of potential advocacy and change, transforming change, is in our role as community organizations. So activities that in this project that we did at the community level was then to take the information that we gleaned from the screenings and referral to inform community conversations. And that meant identifying and recruiting and then engaging with community partners to develop plans for closing resource gaps. Again, very much easier said than done. But the goals here were to try to contribute to a local understanding. I keep saying local because I think that, again, we don't live as much or we don't think we live as much in a local world, but in fact, many of the things that we experience and that shape our lives are, they continue to be locally informed. So we contribute to a local understanding of the actual needs and effective referral and support pathways, and help to develop a consensus and collaborative solutions that are aimed at closing gaps in community capacity, and then ultimately contribute to a national body of evidence that is, around this addressing of basic human needs. But this understanding and true grappling with what resources are out there in a community and how can you effectively refer people to those so that there are fewer people that are dropped, kind of like lost to attrition, or lost, just dropped inadvertently, fall out of the process, and or that they're not referred to a community agency that no longer has resources for them. Understanding sort of these dynamics is really important, and not nearly enough resources are put into buttressing or supporting that network, or the health of those network connections, because it's hard work And in many ways, it's depressing work because the community organizations are often not nearly as well funded as they should be. And so there's a lot of turnover there and a lot of burnout. And so for providers or healthcare systems to be constantly trying to keep updated on what resources are out there and how they can best and effectively refer their patients to those resources can be and is a full-time job in many cases.
The next slide features a colorful infographic with structural inequalities and biases, socioeconomic, and political drivers surrounding community driven solutions, including income and wealth, physical environment, public safety, social environment, education, transportation, employment, health systems and services, and public determinants of health. In the center is text read by the speaker.
But you can see here that it's really the community itself, these community agencies are um, when they survive, they are critical or can be critical to these solutions that many of us face, right? So there are, community-driven solutions are critical because you have these, you can sort of share the resource load, and they're often very creative. There's a lot of amazing people putting a lot of time and energy into community organizations that are all about trying to find solutions that are local to their communities, searching for ways to come up with healthier and more equitable communities in which we as people live and learn and work and play. So fostering this multi-sector collaboration idea and continuing it, nurturing it, not letting it die on the vine, trying to work for it to be more than lip service is just, I can't say enough about how important that is. We can't do it alone. I mentioned earlier that the World Health Organization has pointed to these social determinants of health issues as being about 70% of avoidable mortalities or avoidable negative outcomes. This is the healthcare system alone can't do it, right? The healthcare system is not equipped to do that, but we can be the pathway to other solutions, other resources. And so it's not something that should be just dismissed. It's really critical. And in this project with RWJ and Catholic Health Initiatives, we found that with a lot of work, the community health workers were able to establish really good working relationships with area agencies. There's a lot of failure in there too, of course, but we really tried to put a lot of resources towards supporting that. And that really helped everything. It made the whole machine move. But there were, of course, a lot of challenges, especially understanding what the true capacity of those local communities and local community agencies really was to meet needs. Again, lots of turnover, lots of burnout, lots of change in what organizations existed. And that was really an ongoing issue. As was how to best integrate the technology in order to make those pathways really, really happen. But overall, it was a critical thing. Once we learned how much effort needed to be devoted to identify those good resources and establish those working relationships, it was a different project after that in a positive way. Now, we also need to say a little bit about how we can strengthen leadership accountabilities, because anybody who's ever worked in an organization, which is I'm going to say pretty much all of us in one form or another, knows that really nothing happens in an organization if it doesn't have the buy-in of leadership, which of course makes sense. So for this project, we made a concerted effort to try to develop and provide education for national and local leaders and board members. We created a national learning platform that was, it was moderately successful. It did convey information, but of course, getting people to really pay attention in this age of constant distractions and constant pulls is a little bit of a tall order. But it did help. And we also put a lot of work into trying to assess the current engagement or then current engagement of leadership in local and regional and national initiatives and develop updated performance metrics. That last part was pretty pretty critical, as it turns out, because everyone has well, increasingly, there's a number of organizations that have performance metrics. And that is a language that a lot of leaders are used to responding to. And so creating and developing these performance metrics and integrating those into the conversation and into the work that we were doing made more people pay attention. Um, the uh, the and the attention here was that leadership and governing boards could um, be and feel accountable for sustaining a comprehensive approach to promoting health equity. This, again, it's important because it's not going to happen if they don't buy into it. So so there was a number of goals here and some questions that I offer here for your consideration and your own work. But it's important, to try to assist in connecting to other opportunities and to the momentum of other initiatives. You're trying to make this case to leadership, right? And as you're considering that, ask yourself, who is missing in these conversations? You want to also assist when you're working with leadership and holding leadership accountable in trying to clear obstacles that might come up in their way, facilitating those conversations, making it as easy as possible for folks to take accountability and get really involved and feel invested in what to do. So you want to, if possible, ask leaders or find out from leaders if there's specific elements of the work that are of interest to them. And what you want to determine for yourself, so you know where to intervene at the leadership level, what leadership roles or positions are most influential within the organization for changing culture to support this addressing basic human needs. Because sometimes people have a title that would make you think that they would be the key person, but in actuality, it's another title or there's another dynamic at work, and you really need to try to suss that out as much as you can so that you're not bothering people who don't really have an investment in the work that you're doing. You also, with leaders, want to make sure that you're making the communications and navigating the leadership culture well to promote the advancement of the work, right? Including identifying competing priorities, because leaders are constantly, managing multiple things that need their time and attention. So you want to be thoughtful about how and where and when you should be communicating and who are the key audiences. Of course, you want to develop definitions of success and sustainability because everyone is interested in that. And you want to develop principles of system-wide commitment and the role of the national organization in leading progress. And you want to ask them, where do they think that we should start? So you have here a slide that kind of summarizes, I think, different roles that you can have at a leadership level, for a national team that is devoted to work in this, supporting engaged discussion, idea mining, making connections, overcoming obstacles. I won't read every single one of these because you all have eyes and can look at them yourself.
The other roles include refine the roadmap, develop leadership, develop integrative workflows, assess training and skill development needs, effectively integrate technology, develop useful metrics, document and communicate, convene leadership, network with new partners, manage contracts and agreements, and steward funds and plan for sustainability.
But this is meant to demonstrate just how many different roles there are and different sets of activities that you can focus your work on, and all of them are important. They all kind of work together and are critical for moving forward. Let's see. The last, I'm conscious of time here and I want to give time for some Q&A. So I'll mention here that the fourth aim is also critical, right? Changing policies to support and advance health equity. So policy work is critical. At the beginning of this talk, I mentioned that over the past decade or so of my work, and particularly in the past few years, I've moved from feeling okay about, just documenting or analyzing differences in health equity and feeling this really like an urgency, an imperative to try to move the needle at a policy level too. Because nothing happens without policy. I mean, we live in, we have a lot of agency, but we live within larger structures, and policy creates the structures in which we live. And again, this quote from the World Health Organization: health policy was once thought to be about little more than the provision and funding of medical care. The social determinants of health were discussed only among academics. This is now changing. While medical care can prolong survival and improve prognosis after some serious diseases, more important for the health of the population as a whole are the social and economic conditions that make people ill and in need of medical care in the first place. Nevertheless, universal access to medical care is clearly one of the social determinants of health. So this really says it all for me. The social policy and health policy are the same to me. And this is typically there's a depoliticized approach, right? Where you're only determining the relationship between the social determinant of health and health status. But I would argue it's not depoliticized. Social determinants of health don't exist in a vacuum. They are the direct result of public policy decisions that are made by some actual people. They're out there. And health and social policies are interwoven because social policies are the root causes of health equities, health inequities. And, and so most health policy focuses on inadequacies in healthcare, but that's only about 10% of premature mortality. So we have to address these root causes of unequal health outcomes, and that's the policy part of it. Policy influences population health in profound ways. You can see this whole list of different categories of policies, and all of these influence population health.
The policies include promotes an understanding of the SDOH, education, financial, environmental, workplace, health behavior, and also addresses racial/age differences.
And there is so much work that is needed in this area. There's lots of need for policy improvements. You can see this. This is just huge, right? Look at this. Look at the United States here as this outlier. Life expectancy versus health expenditures. Look what everybody else, all the other countries are over this way, and here we are in the United States spending unbelievable sums of money and really not doing that well in terms of life expectancy. So in the language of leadership, I don't know what our return on investment is there, and it's not good. But the healthcare system itself holds so much power. And we think of these anchor institutions, right? And writ large across the nation, the healthcare system, look at this, great power and great wealth. I would argue too much, especially in comparison for what we're getting back in terms of our outcomes. You see the United States right here. We are an anomaly in health and social spending patterns. And that is something that, I think we often lose sight of. And it's getting worse. So, the US health insurance profits, look at this. It's probably not a surprise to any of you, but lots of profits here in the pandemic times. I'm sure there's plenty of other charts and graphs to show that are not pandemic related, but I found this to be pretty moving. And, ultimately the healthcare sector holds tremendous power, right? And you can see this quote here from a Health Affairs article in 2020. In true American fashion, it uses much of its power to sustain its power, right? This is the system's part of it. This is the logic. The system will recreate itself as much as possible. And so in its pursuit of growth, healthcare has become responsive to the needs of those with wealth. Indeed. And so again, we go back to this burden that the low socioeconomic status folks on that end of the continuum are disproportionately experiencing. So we need to think about the assets that we have in our healthcare system, right? There's a lot of functional assets. You can see them all listed here. Lots of functional assets, lots of discretionary assets, and lots of economic assets. And so transforming the role, or at least harnessing some of the energy of the healthcare system, or of the movement to improve health equity and to advocate for the promotion of better population health. If we can map that energy onto a an appraisal of and intervening at the level of these assets that the healthcare system has, it will be to everybody's benefit. And then I think I'll just close with this slide here, which again is a very busy slide.
The infographic is titled Theory of Change, Total Health Roadmap Implementation, and features a series of strategies and text revolving around a central cycle of increasing community capacity to shape outcomes, engaging in multi-sector collaboration, and making health equity a shared vision and value. Central to all of this is healthier populations and engaged communities.
But this encapsulates the theory of change and some of the work that we did for this project, the Total Health Roadmap implementation of this project that I've been referring to. But you can see how multi-pronged it is, how the strategies kind of kept informing each other, and how it really was not a vicious, it was a positive, but a continual circle. And so the vision here is that for this project, for all the work that I do, and for I'm sure and I hope all the work that you all do, that we can root our value, the valuing we give health equity, and put it really in service to these initiatives with the goal of achieving better outcomes and having some impact in this very large bucket that we're working within. So with that, I know we now just have a few minutes for questions, but I will stop sharing here, and I want to thank you though. Again, please feel free to reach out to me. If we don't get to your questions in this hour, please feel free to reach out to me at one of these two email addresses, and I'd be glad to talk further. I am inspired to talk with you all and to have conversations with people who care similarly about these issues, and I know you all do. And thanks for spending some time with me today. I really appreciate it.
Thank you, Dr. Albright. So we will open this up for any questions that you all may have. I do not see anything in the chat right now, so feel free to raise your hand and unmute yourself if you have any questions. Well, everyone is saying this was a great presentation, Dr.
Good, thank you. Thank you so much. And I really meant what I said. I'd love anybody who's doing similar work, which again, I have a feeling is probably most people in this audience, please reach out to me. It's buoying to me, as it probably is to everybody, to hear people who are working similarly, have similar goals and trying different things. I mean, a lot of this is trial and error sometimes. We have an evidence base that we're all working from, of course, but a lot of it's trial and error, especially when we're trying to innovate. And I would love to hear from you and get ideas from you and share ideas and discussion.
So we do have one question that was in the chat. Can you share how you have been able to move into the space of shaping policy versus just observing it?
Yeah, great idea. Well, so there's several, yes, that is a very good question. So I think there are different ways of doing it, but in my personal experience, what I have done, or at least started to move toward doing, is essentially give testimony and presentations to policymakers. So I'm best situated to amass an evidence base, right? Both through systematic reviews, but also through results of my own studies, and be able to package them in a way that can be delivered in an effective, hopefully impactful way to policymakers at key points. Now, I am primarily at heart a qualitative researcher. And one of the things I've noticed, this is hopefully encouraging for all the qualitative researchers out there, that policymakers, I mean, they hear numbers all the time, but local policymakers in particular really like hearing people's stories. So, harnessing illustrative quotes that really highlight people's lived experiences is often the most moving thing I've seen. So some of the ways this gets played out, a couple of years ago, at the height of the pandemic, our research was used to, and we did this, to argue for emergency Medicaid provision to undocumented immigrants in Colorado for COVID care, as well as a couple of other specific diseases. And that was a huge day. This was the result, not of this project that I've just been reporting on here. That was a huge day and a huge win. And it felt so impactful to be able to have this population that were, I mean, really get they bear the brunt of lots of terrible things in our society, and definitely do not have access to a lot of medical care. But they were able to get care for some in a very difficult time. So that's one example of how my work was packaged, and I helped present that to achieve a specific policy outcome. But I would say in general, that's the best way to be able to, as best you can, wherever you're located, if you can package and deliver compelling statistics, of course, but also compelling stories that will move the needle and appeal. Policymakers are just people too, and to try to reach them behind their often relatively hardened gaze at this point, because they see a lot of tough things all the time.
All right. Well, thank you, Dr. Albright. We are right at 1 o'clock. We did have a couple of other questions that were in the chat, but I do want to be mindful of time. So what I want to do is to thank you again, Dr. Albright, for this really informative presentation. I would also like to remind everyone to please complete the evaluation. So the link has been placed in the chat. And so please click on the link and complete the evaluation. And also, yes, Dr. Albright.
I'm sorry to interrupt. Before everybody drops off, I just wanted to say this. If there's one thing that I would like people to take from my presentation, it's the belief that we can and should be proactive in the face of these, really, it's a hard world out there. We're all aware of that, but if we don't do anything, then the bad stuff wins, right? And it's a noble and worthy and it's a noble and worthy set of activities, no matter where you decide to intervene or what your skill sets are or what your level of interest and resources are. All of it's worthwhile, all of it, so sorry, it's a little over the top perhaps, but I really mean that. I just want to encourage people to remember that there's a million ways of doing good.
Definitely. So thank you again. And please be on the lookout for our next learning series, which will occur in April. So thank you all.